sophisticated, cutting-edge tool that people are often using to identify those at significant risk.
Yeah. In relation to that, you know, in my practice, what we do, we have a lot of, just because I'm a woman doesn't mean I only take care of women. I would say probably 30% of my practice is men. And I've got that 30-plus age that are starting to have complaints of erectile dysfunction. And the feeling is that that may be one of the first indicators of coronary artery disease. So we need to work them up. And so what we do is, you know, besides doing testosterone levels to make sure it's not a hormonal thing, we send them because everything says that those arteries don't vasodilate, and that may be the first indicator that somebody's having difficulty, and you really need to extrapolate that and take a look at what their coronary arteries are doing at the same time.
Absolutely. I mean, I think one of the most important things is that, you know, when you talk about atherosclerosis, it's not a disease just of the heart arteries.
Right, and I think people think that.
Exactly. It's a systemic process. It's essentially affecting every artery in the body. And, you know, if it's present in one territory,
right,
it is very likely, and some people have even quoted statistics of having like a 66% chance that if you have carotid artery disease that you're going to have coronary artery disease, or if you have peripheral arterial
right,
disease, that you'll have coronary artery disease. And this is so it's very important to recognize that this is a systemic process, and that what we do understand about the disease, the smoking, the cholesterol, the blood pressure, the lack of exercise, the diabetics, the older we get, these are just traditional risk factors, and that many studies are currently ongoing to identify other factors that might be contributing to this process, and how we target those entities that are contributing to this risk, and how we identify patients much earlier, whether it's recognizing in young folks who have erectile dysfunction, or recognizing this absence of appropriate reactivity, or having an abnormal MCG, or even for that matter traditional techniques, stress testing, whether it's an echo stress test or a nuclear stress test. If those folks are, if you can identify folks early, you clearly have a shot at potentially preventing process from progressing quickly.
Right. Now, what do you feel about diet? There's this whole thing, you know, as integrative medicine, a big part of what we do is prevention and least invasive kind of natural ways of dealing with things. And there was this study that the Mediterranean diet, they followed patient, and I think it was Framingham, that realized it was supposed to be like a 5-year study, and they stopped it in 27 months because they realized that the benefits were so incredible that they didn't even want to bother doing it for 5 years, that it can decrease your risk of coronary artery disease by 73%. It does nothing to lower your cholesterol or change your numbers. So nobody really knows how the Mediterranean diet works, but that compared to like statins in risk, not in lowering cholesterol numbers or changing your HDLs, but in your risk, with statins being 22 to 32%, and then the Mediterranean diet being 73%. What do you think about that as like do you tell your patients, do your Mediterranean diet?
I do. I think that the study that you're quoting, it's actually a very interesting finding about how powerful our dietary intake is as a variable that can influence the presence or the risk of one having a heart attack or a stroke. You know, there's a lot of data out there and a lot of opinions about which
right,
diet is the best. You know, there was a study just recently in the Annals of Internal Medicine comparing the low-fat diet to the Atkins diet, and
right,
whether or not, which is a high protein but high fat content, and the other diet was a low fat but high protein content, low carb.
right.
And essentially after 2 years in this particular study, there was no dramatic difference in terms of the amount of weight loss that one had, and that was sort of one of the primary endpoints of the study. But what's interesting is that, you know, again, if we go back to the principles of how do you affect vasoreactivity, is fat content in your meal a critical contributor to absence of appropriate vasoreactivity? And if so, then maybe lower fat, high protein makes you lose some weight,
Right.
might not be any better than the high-fat, high-protein diet in terms of weight reduction, but does it have less influence, a less negative influence on the blood vessels? And so when it comes to the Mediterranean diet, these are very critical findings, because now we can talk about what type of fat
Right.
is one eating. And so we know, and I think in our lay press, we are hearing more and more, from our senior level federal authorities who try to help influence or change what is available to our kids and to adults in terms of food, quantifying how much fat content is at any restaurant when you order a meal, or knowing yourself what you're going to be
Right.
preparing at home. Recognizing not just the total amount of fat, but what kinds of fats are you going to be consuming, and recognizing things like the saturated fats are clearly the worst form of fat that one could ingest, because they have the worst impact on that blood vessel reactivity. So the Mediterranean diet, which, like you said, may not alter your cholesterol levels, which then go on to, that's a whole other discussion as to what are the key parameters within a cholesterol profile to assess. But it may not alter your cholesterol profile, but the type of fat that's being consumed in that diet are more polyunsaturated fats, okay? And so the oils that are being used, the fat that's being ingested, the types of calories that are being ingested are clearly much more, if you will, blood vessel friendly than those that might be of a more traditional higher fat content diet, but more saturated fat content
Right.
diet. So I think that's probably the simplest way to try to think about it, where the advantage might be clear that the Mediterranean diet has such a superior effect on events compared to even our most powerful method in this country, which would be to say you have high cholesterol, you go on a statin, as opposed to considering a more aggressive modifying lifestyle strategy and avoiding, if you will, the medication, but still influencing your outcomes in a positive way. It's a very interesting body of information that when you consider what are the options and how are you going to influence your food intake and how are you going to influence your medication intake, it's clearly not something that there's a simple answer to, right? Your choices, your likes and preferences may be different than mine, and when I talk to a patient in the office, I would love to say you need to be on a Mediterranean diet and
Right.
you need to eat totally less than 30 grams of fat a day, not 30% of your calories being of fat content. But you can't do that. But you have to give guidelines. And so what we try to do is instruct folks about recognizing the advantage of one option over another, and then generally giving guidelines in terms of total number of calories to take in, how many grams of fat they should take in per day in total. And that at least creates a level of consciousness, whether you're in the supermarket purchasing food or whether you're sitting at a restaurant table ready to order a meal. If you've been keeping accounts of what's been going in,
Right.
you'll clearly recognize that in value, you'll know that you're going to be doing or making choices that are going to be relevant to protecting your well-being down the road.
Yeah, and you're right. I think rather than giving a patient, like a diet and saying, okay, follow this,
Right.
where sometimes people get overwhelmed, because if you actually look at like that food pyramid, a lot of it people find difficult to make those changes, but if they can pick one thing, like not doing the saturated fats, doing more olive oil,
Right.
cooking with canola oil, having a handful of nuts a day,
Right.
and then make that change, then if you go month by month, you can make those changes till you're eventually really have altered the way you eat. Because doing it all at one time, it's just basic. It's a recipe for failure.
Absolutely.
Because people can't do it. And you're right. Everybody has their own ethnic foods too that you have to work into that.
Exactly.
I made pasta the other day, and I didn't tell Dennis, my husband, that it was whole wheat, because if I would have said it was whole wheat pasta, he would have said, I don't like it.
Yeah.
So as he was eating, I was like, how's the pasta? He was like, it's really good. So then I went, it's whole wheat.
Yeah.
But those are the little changes that make it easier for people to make changes. But you're right, you can't just tell a patient, all right, this is what you have to do, because it just doesn't get done.
I can say that, in the office when we see patients, and we obviously see a skewed patient population in the cardiologist's office. At least in our office, what we're seeing is a lot of folks who already have advanced disease, or they've had multiple stent procedures to open up these blocked arteries, or they've had bypass surgery, or they've had other interventions to help improve their heart muscle function. And so in that patient population, there is potentially more imperative to make changes and try to sustain them. But what's interesting is that even in that patient population, maybe early after their stent, for example, they make some changes, and they're often drastic changes.
Right.
And you see them, and they're really good for 6 months. They've lost some weight, they're exercising regularly, they're absolutely pristine in the meals that they're eating, and then something happens in their world. They go on vacation, somebody moves in, they have a work-related event that becomes ultra stressful, and all of a sudden, one indiscretion, becomes two, and it's tolerable, and then it becomes, and you slowly develop your old habits again. And so what I always try to instruct patients to do, whether it's those that have never had any interventions versus those even who've had interventions, is to make the changes that you think you're going to be able to live with.
Right.
Because if you can live with them at 6 months, then it's likely that you're going to live with them at a year and onward. If you're going to make changes that are making you, it's not that you can't discipline yourself for a period of time to make those changes, but it's becoming difficult and more difficult to maintain that level of discipline for yourself, then, like you said, choose a few things that you can definitely commit to.
Now, if you had to pick 3 things that you would tell the audience, the changes that would be most beneficial, what would those 3 things be? Yeah,
that's a great question. So, I think that if you are a smoker, the number one thing would be to stop smoking.
Right.
If you're not a smoker, then the number one thing would be regular exercise. And regular exercise, based on American Heart Association guidelines, the ACC guidelines, usually we talk about between 30 and 60 minutes of exercise at least 3 to 5 times a week.
Okay. And the other 2?
And the other 2 things that I think are critical would be less than 30 grams of fat a day total if you have coronary artery disease, and up to 60 grams of fat a day if you have no significant coronary artery disease. So be ultra strict about your total fat intake.
And number 1?
And number 1 thing that I would tell you is that if you have coronary disease, your aspirin and your statin are fairly traditional in terms of their power to prevent heart attack and stroke. And so I would be committed to those 2 types of medication as being very powerful indicators that you could make and embrace as ways to alter your lifestyle. And I know that goes against the just without medication, what are the 3 things to do?
No, that's
they're ultra powerful.
The 3 things, I asked 3 things.
Yeah, that's what I would do.
Well, thank you, Binoy. This is really good. And I hope everybody takes his advice, and I will see you next month. Thank you.